All right. Hi, everyone. Welcome to our webinar, and thanks to everyone for joining us today. My name is Natalie Doran. I am the Director of Customer Support here at Diagnosis, and it's my great pleasure to join our speaker today, Dr. Wendy Harrison, who's going to be giving a presentation titled Combining Visual Electrophysiology with Other Testing and Genetics in Real-World Vision Care Practices. Before I introduce Wendy, a few quick items, a few housekeeping items. Wendy's going to present for about 30 minutes, and that will leave about 30 minutes for questions from our audience. Wendy's very interested in answering any questions you have, and we will get through as many of those questions as we can in the session today. If you do have a question during the presentation, please open the question pane and type it in. You can open the question pane by clicking on the small question mark in a box. It's in the upper right-hand corner of your display. I'll pose your questions to Wendy in the Q&A section of the webinar. I'd like to now introduce and welcome our speaker, Dr. Wendy Harrison. Dr. Harrison graduated from Indiana University with an OD/MS degree. After completing a cornea and contact lens residency, also at Indiana, she went on to complete a PhD at UC Berkeley. She graduated in 2011 and joined the faculty of the Arizona College of Optometry, where she worked for 6 years. Dr. Harrison's currently an associate professor at the University of Houston. Her research lab is funded by grants from the National Eye Institute and focuses on biomarkers for early detection of diabetes. She runs the Diagnostic patient clinic, and she teaches ocular disease. She's also an active member of the American Academy of Optometry, where she is a fellow and served on the board of the Academy's foundation for over 10 years. She's also a member of the Association for Research in Vision and Ophthalmology and the American Optometric Association. Wendy, welcome. Thank you so much for joining us today.
Thank you, Natalie and Mark and Diagnosis for having me today. Hopefully everybody can hear me. I do have a little bit of a cold. If you meet me at Arvo or one of these other meetings, hopefully I won't sound quite as scratchy as I do today. But certainly if anybody is having difficulty hearing or understanding what I'm saying, please let me know. I want this webinar to be helpful for everybody. Today I'm going to talk a little bit about the patients that I see in my clinical practice. So like Natalie said a few minutes ago, I run the electrodiagnostic service for the University of Houston. And in our practice, we do various electrodiagnostic testing on referred patients. And we combine that electrodiagnostic testing with genetics, with other testing, in order to come up with good diagnoses for our patients. I'm going to talk a little bit about how that happens in our clinical practice, and I'm happy to answer any questions to help other people be able to implement this in their own practice as well. I'll see if I can, there we go. All right, so over the last couple of years, genetics in clinical practice has become more attainable. So it used to be that we really only had access to genetics in research environments or when patients were willing to pay a great deal of money in order to have access to their genetic testing. But now in the United States, especially with the Foundation for Fighting Blindness Retina Tracker program, we have access to be able to get genetic information for a lot of our patients with inherited retinal diseases at really no cost to the patient, which has evolved these practices to give us more information for these patients. So one of the questions I get a lot from the patients and also from other practitioners is, if we have all of these genetic tests, then do we still need to be doing ERGs on all of these patients? So the patients will sometimes call me up and say, well, I already have my genetics back and I know what it is. So do I still have to come in and see you? And of course, I think the answer to this question is yes. I do think that ERGs still have a very important place in clinical practice, can help us with following patients, and can give information that the genetic testing sometimes doesn't give, or combining the two together can be very helpful. So today I'm going to talk about some cases where really having both tests, both the genetic test and the electroretinogram, help to give us the full picture of what's going on with the patient. So I'm going to start off by saying that a lot of the information that we can get on our patients now is not new. We've been able to have access to genetic testing and ERGs for quite some time, and in various research studies that have been done here, both at the University of Houston and worldwide. It's really common for us to be able to gather this testing. So the first case is a case from research. This case was seen mostly by Dr. Kristen Bowles-Johnson, who completed her PhD here with Dr. Laura Frischman at the University of Houston College of Optometry. And now she is a postdoctoral fellow at Indiana University. And Kristen's PhD focused some on looking at genetic testing and how genetic testing and ERGs go together, and she shared this case with me to share with you guys today. So this is the case of a patient, LK, who's a 20-year-old Caucasian female who was referred from our low vision clinic for genotyping and phenotyping. And so in this research study, they were able to go through a company called iGene, which gives genotyping information. And then from the study, the ERGs and the other testing, they were able to get phenotyping information for these patients as well. So the patient complains of photophobia, difficulty determining colors, and she reports stable vision, but her vision is reduced. She did have a nystagmus as a small child and noticeable photophobia before she was 1 year old. She's had an ERG before. She came in to be in this study at 13 months old, which suggested that she probably has achromatopsia. And achromatopsia is the working diagnosis for this patient. The nystagmus dampened by the time that she was 3 years old. So the patient, kind of continued to develop, and some of her eye signs changed as she got older. Again. I'm trying to get the slide. Oh, there we go. It may advance now a couple of times and then make me come back. So there's no consanguinity in the patient's family. Her mom had some thyroid disease, but nothing, alarming or concerning in the patient's family history. The patient was taking oral contraceptives, but really had no medications or allergies that are important for this testing. She's a college student. The first thing that I want to call your attention to is her autosomal recessive pedigree. So in these research studies, we were able to determine the pedigree for the patient. So you can see both her mom and her dad were carriers for this condition. And here she is here. Come on, slide. There we go. So her clinical findings, she was wearing a tinted red contact lens. She's about 2100 in both eyes, which is slightly better vision than you would typically expect for an achromatopsia patient, but it is in the range. And her visual acuity was aided with a low hyperopic prescription. Everything else in her clinical findings was unremarkable. All right, this is what the patient's fundus looks like. And here you can see that it looks pretty normal. There may be a little bit of mottling in her macula, but overall the periphery looks normal as expected. This is the patient's OCT, and you can see here the classic achromatopsia OCT, where there's no central cones. So the patient has this kind of bubble-like appearance in the OCT, and this is classic for achromatopsia. They did a full field ERG in order to assess her rod and cone function. First, they did the dark adapted ERG. So this is dark adapted 0.01 and the dark adapted 3.0. And you can see the typical A and B wave here. This is the normal results for our instrument as well as the results for this patient. What you can see here is there's a slight difference in the shape of the waveform for the dark adapted testing for the patient, right? So, the ERG does not look exactly like the normal controls for the rod function, but there is good rod function in both eyes. And what you can see here is the cone function. In achromatopsia, we expect really no cone function at all. This patient, if you look here at the waveform, does have a little bit of a photopic B wave, and a little tiny bit of a photopic A wave. So her photopic ERG is not completely extinguished. She does have a small cone response. She doesn't really have a light adapted flicker response, but there is a little tiny bit of cone response there. And this goes along with the fact that the patient is 2100 and not closer to 2150 or 2200, right? And adds more information to this case. They did test her using a really anomaliscope, which is a gold standard color vision test. For those people not familiar with the anomaliscope, you look into this tube and there's this field that's divided into two hemispheres. On the bottom hemisphere is a yellow color at a fixed wavelength. It's a spectral yellow. And then the top of the circle is a mixing field where you can mix together two different wavelengths, ideally to match the bottom of the field. And in protanopia, deuteranopia, and achromatopsia, the patients will have color vision matching that falls in these distinct bands, right? So this kind of green circle that you see here is the expected color matching for somebody who's deuteranomalous. The red circle here is for somebody who's protanomalous. And then this band here that I'm highlighting with my cursor is the band that would be expected for somebody with achromatopsia. And this patient can match the colors with two different sets of wavelengths, both at the very top and the very bottom of the achromatopsia color band. So her genetic testing came back, and she did have two mutations in the CNGA3 gene. This is a gene that is responsible for achromatopsia. One of the interesting things about these particular mutations is that when you look in prevention genetics or you look in the genetics information, these are classified as a variant of uncertain significance. So when you get back a genetic testing report, the genetic testing report will either classify the gene that you're seeing as pathogenic, as not pathogenic, or as a variant of uncertain significance. And when you get this kind of middle ground, this variant of uncertain significance, it leaves a lot of questions for those of us trying to interpret the results. So I kind of take the variant of uncertain significance as a maybe, right? Like we've detected this change in a gene that we know could be responsible for things that are important in the eye, but we're not really sure if this particular protein change or this particular change in the DNA is going to have a deleterious effect, right? So it's a maybe, and I feel like we get this a lot in our genetic testing where we get these uncertain significance variables. But as we can see from this patient, from her fundus findings, from her color findings, and from her ERG, is that she does have some form of achromatopsia, right? So it's probably not a complete achromatopsia because the patient does have a little bit of residual B wave on her ERG. But this is not completely insignificant. These genes are contributing to the fact that the patient does have achromatopsia loss. So our assessment for this patient, again, is incomplete achromatopsia, second to a mutation in CNGA3. Her visual acuity was better than the expected 2200, but she does have some photopic ERG response that leads us to believe that while she does have achromatopsia, it's not a complete achromatopsia. For this patient, we decided to continue with the early eye exams and low vision exams. She was wearing a red tinted contact lens that she decided to continue with. She was given a copy of her genetic testing for family planning purposes, but she was not interested in any kind of referrals to any gene therapy trials. All right, so that first case highlights, how we've been completing this genetic testing in research practice for some time. Again, more recently, with the Foundation for Fighting Blindness My Retina Tracker program, we've been able to get access to genetic testing results in our clinic patients more quickly and readily, to be able to see what's going on with their genetic testing. So now I'm going to go through some cases that I've seen in our patient care clinic where the patient was referred in for an ERG and where we did genetic testing that helped to give more clarity to their case. So this first case is a 54-year-old Hispanic female. And she was referred for an ERG. She has a strong family history of retinitis pigmentosa. She has done an ERG in the past, which was not normal, but did not necessarily point to retinitis pigmentosa. But she felt like her vision, and especially her visual field, were getting worse. She's 20/20, but with sections of field loss. And her retinal appearance does not match the classic appearance of retinitis pigmentosa. So there's no bony spicules, and there's no optic pallor. And this is a picture of the patient's retina. So hopefully what you can see is that there is some pigmentary changes in the posterior pole here, kind of where I'm circling, in both eyes, right? But no clear bony spicules, no clear optic pallor, and the vessels do not look severely attenuated. This is the patient's autofluorescence, which again does show substantial change in her mid-periphery, due to her retinal findings. Again, there's no bony spicules present for this patient. This is her visual field, which does match the patient's visual complaint for both eyes. She has kind of a ring scotoma or bullseye scotoma, which matches the fundus appearance that we've seen for the patient. This is her ERG the first time that I saw her. This is a comparison of the right eye and the left eye. And I do think that this ERG looks like retinitis pigmentosa. It has rod loss in both the A and the B wave in both eyes, and it has cone loss and delay in the cone B wave. At that same visit, we did a multifocal electroretinogram, and here you can also see a bullseye appearance to her multifocal ERG, where she has some remaining central elements of cone function, but there's a lot of extinguished cone function as you kind of move into this middle area of the posterior pole, right? And then she regains some function farther out, closer to the 45-degree expanse. The bottom are the control references. So this is kind of what we expect the size and the shape of these waveforms to look like. And she came back again about 2 years later, and we were able to repeat this ERG. And it does look, this is the ERG of her left eye against the previous ERG. And what you can see is that there has been some progression in this ERG which also matches retinitis pigmentosa, which we would expect to progress. So now that we have an ERG showing retinitis pigmentosa, but a fundus appearance that is ambiguous for retinitis pigmentosa, we went ahead and ran the genetic testing report. And this genetic testing report came back positive, as you can see on the slide that I'm sharing, for the SAG gene. And SAG is responsible for both autosomal recessive Gucci disease as well as autosomal dominant retinitis pigmentosa. So as you hopefully remember, the patient has a strong family history of retinitis pigmentosa. And so autosomal dominant retinitis pigmentosa matches up well with this particular case. And so we were able to give the patient the information about what gene it is, which helps not only her, but her children and the rest of her family. It's important to note that when you get these genetic testing results, and I'm going to jump back a slide, right, it gives you multiple clinical conditions that can match the genetic testing report seen, right? So that leaves it up to the practitioner, right, from knowing from our exam if this is more likely to be an autosomal dominant retinitis pigmentosa, or does this patient present more of an Oguchi disease, right? So I know from looking at the patient's ERG and also looking at the patient's fundus appearance in her field and her family history, which is strong for RP, that this is autosomal dominant retinitis pigmentosa, right? So the genetic testing report doesn't necessarily give you the information about what condition you're dealing with, right? It gives you the gene, and then you have to use your clinical expertise in order to figure out how that gene is manifesting in this particular patient. So in this case, the ERG results, right, showing clear retinitis pigmentosa are able to help me supplement the genetic testing results for these patients in order to show, right, that the patient does not necessarily have a Gucci disease, but does but likely have autosomal dominant retinitis pigmentosa. SAG is a common retinitis pigmentosa gene in the Hispanic population. This patient was Hispanic. And again, for various reasons, it's important for the patients to know if their gene is dominant in transmission. Going forward, I'm going to talk a little bit about IRD vision loss in children. So this patient was a 9-year-old male who was referred for unexplained vision loss and high myopia for an ERG. He was 20/50 in one eye and 20/80 in the other eye, and his refractive error is about a -7. This is what his fundus looks like, and I'm going to spare everybody the time of really looking deeply into it. His overall fundus appearance is pretty normal. There's not really anything wrong in this picture. So we ran a full field ERG on this patient, and what you can hopefully see from this ERG is that this patient has pretty normal rod function, but very reduced cone function, right? So down here at the bottom, the expected location of the cone A wave and cone B wave, you can see the light adapted ERG there does not really go through either box, indicating that there's a fair amount of cone loss in both eyes for this patient. So we went ahead and ran the genetic report for this patient and found that he has a defect in the gene RP1L1, and then also a questionable variant in ABCA4. So if you look at the information that they provide you about the gene present for the patient, I put here in a box that this gene is responsible for autosomal dominant occult macular dystrophy, right? And this patient's clinical appearance does match an occult macular dystrophy. So this genetic information is very important. One of the other things that I note in this report is that this condition is characterized by a central cone dysfunction, which we definitely see on our electroretinogram. But it also says that you can expect often a normal full-field electroretinogram, which we did not see in this patient. We only saw normal rod function. We did not see normal cone function for this patient. The other thing is that it points out, other information that could be present for this patient that we need to consider, right? In this case, it points out things like this gene can sometimes be responsible for retinitis pigmentosa, right, and other conditions. So this patient does not appear to have retinitis pigmentosa from their electroretinogram. They have normal rod function and reduced cone function, right, which points more towards a cone-based dystrophy rather than an RP. So again, we're using our ERG results in order to help us better explain our genetic testing results and really get the answers for these patients. So overall, these two cases so far demonstrate how the ERG and genetics together help to give us the proper case information for the patients. If you just had the genetics and you didn't have the electroretinograms for these patients, you wouldn't necessarily be able to come to the conclusion of which clinical condition the patient has. Right, with both sets of testing results, it's possible to give a more accurate diagnosis for the patient. So I'm going to finish up here by just showing a couple of different patients who are found to have the same genetic result and how we're able to use the clinical findings in the ERG to give more information for these patients. So all of these patients are going to have a bullseye maculopathy. The first is a 38-year-old Black female who was referred for an ERG. To be honest, she didn't really care that she was there for an ERG at all. What she really wanted was me to fit her with some contact lenses. I said the only contact lenses I had that day were Beery and Allen contact lenses. But I did think that she was probably fine to be fit in a soft contact lens at a future visit. She has no family history of any eye problems. She does have children that she's interested in knowing her results for. She was told she was going to lose all her vision, so she was a little bit scared about that. She was looking for some answers and also some contact lenses. She's 20/30 and 20/80. Her pupils were normal. This is a picture of what the bullseye looks like on our fundus. You can see that it is fundoscopically obvious. These are her fields, which show some superior loss on her 10-2. So it doesn't necessarily look like a complete bullseye on the visual field, but there's definitely loss there. This is our color vision testing, which is also abnormal, mostly in a Triton direction. And our OCT also shows that clear bullseye. Her ERG and multifocal ERG show loss of cone function. So you can see the multifocal ERG here shows cone function loss consistent with her field, where she has a section of lost cones that kind of include the fovea in the region above it. On her full field ERG, there is overall loss of cone function, and there's questionable loss of rod function. So when we look here at the dark adapted ERG, it's kind of right on the borderline of what I would expect for our instrument for dark adapted rod function. So I wasn't convinced that there was a problem with rods, but I had questions of maybe there being issues with rods, and definitely thought that there were problems in the photopic system. So I diagnosed her with a cone rod dystrophy. I told the patient that it was probable that she would lose more vision, but that I wasn't sure. I told her it's fine to go get fit with contact lenses, and I referred her to our low vision clinic. We ordered her genetic testing, and she came back with one variant in ABCA4. So just for the record, when you get one variant in a condition, it will show up here as that variant being pathogenic. However, when you look through the information on the genetic testing, it will tell you that this gene is associated with cone rod dystrophy, which we see in the ERG. But it will also tell you that the result is insufficient to cause an autosomal recessive ABCA4 related condition, meaning the patient is a carrier. Right? Carriers do not usually show the phenotype of the condition that they carry, right? They usually have fairly normal appearing retinas from the other normal copy of their condition. We know from the patient's ERG, as well as from her, um, overall fundoscopic appearance, that this patient has a cone rod dystrophy, right? So I do not necessarily agree that this genetic result is insufficient to show this autosomal recessive condition. It does look like this protein, at least, has partial penetration to be able to have some changes in retinal structure and function. The other thing, just really fast about this genetic report, is that it also says it's possible that this patient could have Cohen syndrome from her genetic testing results. I know from meeting the patient and doing her exam that she absolutely does not have Cohen syndrome, right? So me knowing her ERG results as well as her other testing results allows me to rule this out as a possibility. So, what does it mean? It means that, having the ERG results and knowing about the patient's fundus appearance can add more power to the genetic results. Even though the genetic results sometimes say the patient is a carrier, we can sometimes see these changes coming through in real world situations. I have another case of pretty much the same gene showing the same thing. I want to give credit to Sarah Gleason for sharing this data with me. So this is an 18-year-old male. He's 20/25 in both eyes, so a little bit better acuity than our last patient. He's in pigmentary macular modeling. This is what his retina looks like. And you can see the changes better on fundus autofluorescence. It's a fleck retina that kind of looks Stargardt's-like. Right? You can see these changes in his macula on the OCT. You can see that he has a normal retinal nerve fiber layer. And here's another copy of his OCT, right? And you can see these bullseye changes here in the outer retina. His visual field also shows a bullseye. And his ERG shows a normal dark adapted B wave and a reduced light adapted B wave. Right? So just like the previous patient, this patient was found to be a carrier of the ABCA4 gene. But again, just like the last patient, this patient clearly has penetration of these changes causing cone or cone rod dystrophy in their phenotype. So same result here. And again, I think the ERG can really supplement the genetic testing results that we're getting. So I'm just going to finish up by showing a case where the patient does have two copies of the ABCA4 gene. In this case, we would expect a change in both genotype and phenotype. This patient was referred for an ERG and an EOG. She's 2060 and 2040. So again, has similar acuity to our first patient in this series. She has some central and night vision loss, just like the other patients. And she has two copies of pathogenic changes in her genetic testing results. So interestingly, another thing that you don't learn from the genetic testing results is if these two gene changes are on the same gene, right, or if they fall on opposite chromosomes. And so, that's a piece of information that we don't necessarily get from the genetic testing that, you may need to talk to a genetic counselor about or really lean heavily on your other clinical testing results. So here again, there's two copies. And so this says the patient should exhibit a lot of the changes that are expected. This is the patient's fundus result. This is her autofluorescence. Again, no bony spicules for this patient, but she does have a similar retinal appearance to this egg patient that I showed at the beginning of this talk. So here you can see her bullseye OCT. Her ERG shows both cone and rod changes on the dark adapted and the light adapted ERG. And so overall, to kind of try and wrap up here on time, the ERG provides useful and helpful information about the visual system that can be really additive to our genetic results, right? So if you just have the genetic results and you don't have the ERG, then you're missing part of the complete picture. If you just have the ERG and you don't have the genetic results, right, then you don't always have the complete picture. If you have both tests together and you're knowledgeable on kind of reading both sets of tests, you can really provide an important service to your patient by being able to give them an accurate diagnosis, which can help to give kind of potential prognostic information. It can also let them know, depending on the gene, if they qualify for different clinical trials, right? The gene RPE65 does have a treatment, a gene therapy treatment available for it, right? So being able to use these tests in conjunction together in clinical practice is easy to do. And I would argue that, if you're not considering both running an ERG and doing genetic testing on your inherited retinal disease patients, that you're missing part of the picture. So, I do have a couple of slides on just the kind of the nuts and bolts of how to do the genetic testing if you're in the United States and you're not doing genetic testing in your practice and you want to sign up for the Retina Tracker program. But I think in the interest of time, if you're interested in finding out kind of how to sign up and how to actually do the testing, maybe I'll ask you to send me an email or a message, and I can share those with you offline. So I'll go ahead and stop here and give it back over to Natalie for any questions. Natalie, I can't hear you. You're muted.
Sorry about that. Wendy, thank you so much for that. We do have a couple of questions in the panel here. So I'm going to go ahead and start with those. Is there any specific training on genetics you would recommend so that an ophthalmologist can feel comfortable using that in their practice?
So there's no specific training that I would necessarily recommend. I always preface when I'm talking to my patients that I'm not a geneticist, that I'm an eye doctor, and that what I'm telling them comes from a combination of their genetic testing report, as well as what I know already about their eyes. So there are a couple of good websites that will give you additional information about the genes. So I usually, when I get the genetic testing report back for a patient, I usually read what they have to say in the genetic testing report, but then also additionally look up information on the genes myself. And I will also, if I can, look up in the medical literature to see if anybody has published anything on those genes, prognosis from those genes, and to see if there's any patients published in the literature who look similar in retinal appearance and ERG to my own patients, so that I can give them that information. Most of the programs that allow you to do genetic testing do also employ genetic counselors to talk to the patients. So I feel like a combination of talking to the genetic counselor and talking to a person that knows a lot about their eyes and their eye testing can put all this information together for the patients.
In the first case study, do you see a benefit in repeat ERGs?
In the very first one, the achromatopsia?
Yeah.
Yeah, I do think that repeating the ERG every year to couple years could be helpful, particularly because this patient had an ERG when she was very small that pointed toward achromatopsia, but missed the fact that it was an incomplete achromatopsia. So, achromatopsia itself should be a stable condition. So you should get the same ERG result if you were to repeat the test again in a couple of years. But I do think that it would be helpful to know that and also know how the small amount of cones that are there are functioning. It may also be helpful to add a multifocal to be able to see if you can see any of those cone function present in the multifocal, or if the areas are kind of scattered or concentrated together.
Do the red contact lenses help with the patient's ability to detect contrast?
They can. So a lot of it with achromatopsia depends on the lighting. So in certain lighting conditions, the red contact lenses can help them significantly. Additionally, a lot of my patients have different filters on their glasses that help them to see better contrast or see differences in what they're looking at. But it really depends on the lighting condition. If the lighting condition is dark, right, then still having the filter reduces the amount of light that's making it to the back of the eye and can sometimes hinder their visual ability, right, depending on how much light is there.
I have another one. It's a two-parter.
Yeah.
How have you perfected getting reliable ERGs on pediatric patients? Do you have any tips or trips or tricks or guidance for people interested in doing pediatrics?
Yeah, so I find in pediatric patients, a lot of it is about the individual kid and the electrodes that you choose to use. So in general, on most of my ERGs, I prefer to use a Burien Allen contact lens electrode because it's stable and it holds the eye open. And I feel like having the electrode straight on the cornea really gives really good results. But kids in general, especially under the age of about 9 or 10, do really poorly with Burien Allen contact lens electrodes. So with kids, I would recommend either going with a DTL fiber electrode or with a skin electrode that are just a little bit less invasive. So if you're going to do a DTL fiber electrode, usually they do okay with that. I would still put in the proparacaine with the DTL fiber on kids. Like with some, I tend toward using more proparacaine rather than less proparacaine on my patients in general. So I'm liable to put in proparacaine with most DTL fiber electrodes, although there are a lot of patients that could do an ERG fine with a DTL fiber with no proparacaine. With kids, I'm going to use proparacaine 100% of the time, and just making sure that those like little fibers stay together and are like put into the eye correctly so that the kids don't kind of like pick at them, right? And they don't get their eyelashes. They also do okay with the skin electrodes, because nothing has to go into their eye. And the issue with the skin electrodes is that their signal to noise on the skin electrodes sometimes isn't as good as the corneal electrodes are. And so when I see like a negative result or an extinguished result in a child in a skin electrode, I always wonder if I was able to get a corneal electrode on that kid, would I see some function there, or is it truly extinguished? So I think with kids, it's a lot about the electrode, and then also, doing things like, counting down the flashes and things like that, where they feel like they can kind of participate in the test. So if I'm going to do, a photopic flash, like a light adapted flash on a kid, I would say, now we're going to do 15 flashes, right? And so, and with a kid, they can move a little bit during the ERG and it's not really going to hurt things. So I usually ask them, we'll all count to 15 and let's see who can count to 15 the fastest. Is it me? Is it you? Or is it the ERG? And I always make it so the kid wins and counts to 15 the fastest, right? But then you have 15 photopic flashes because we're waiting, right, for everything to catch up. So it doesn't work great on every kid. But, generally I feel like I'm pretty good with kids. And I just, kind of keep talking to them and keep them awake. But the electrode choice is probably the key piece of information for kids.
To add one or two things onto that, I do know a site or two that use incentives. They'll go to the dollar store or local equivalent and buy armloads of cheap toys. And if the kid behaves, they get to pick something out of an assortment of stickers and fidget spinners and little stuffed animals and the like. So I know that's one thing some sites do. And then Diagnosis also, not turning this into a sales pitch, but Diagnosis also has some protocols and some stimulators that are specifically adapted for doing tests in young kids. So if anybody's interested in pediatrics, feel free to reach out. Follow up. The second half of this question was, do you have modified normal values for pediatric patients?
I do for my multifocal. I have a set of norms that goes down into a little bit younger ages. So I kind of use two sets of normative data, a younger set and an older set. And most of the patients I would use the normal set against. But then for the pediatric patient, I don't have a lot of small kids who have volunteered as normals, to be pediatric normals in the multifocal. But, I have some, teenagers, right, that have ERGs that can be included in the normals file. And then my full field ERG file, tries to span as many age groups as possible. So I don't pick out normative data in particular for the full field, but I have a pretty wide age range in those normative controls. And the normative controls that we have are specific to the instruments in our research lab and in our clinic. So, we're not, there are like normative controls available in the literature that are good to be compared to. But if you can have your own specific site controls, I think that is better.
Another question regarding pediatrics. What is the youngest age you've performed a multifocal on kids? And do you have any special techniques or advice on that aspect as well?
So the youngest age I've done a multifocal on is probably around 6 or 7. And again, it's really very kid dependent. So this particular little kid was fantastic. Really like very mature for his age, and just kind of, sat there like a pro. And he was able to wear the Burien Allen contact lens electrode even. I feel like I can always tell if the kid can do it when I go to put the drops in their eyes. If they are kicking me and screaming and flailing, right, they're not going to wear a contact lens electrode. If they are, cool and calm and collected, then maybe they can. One of the issues that you have in the multifocal with kids is that it's just so important for them to fixate, on the cross while they're doing the test, right? The cross is not terribly exciting for them to fixate on. So I do feel like sometimes I have to, kind of move them away, recenter things, make sure that they're ready to go again, give them a drink of water. But then, you're also balancing that with them not wanting to wear the electrode for a long period of time. My youngest ERG patient awake was 3, and she did okay, but it was a lot of like chasing her around with a handheld ERG. It was not the easiest exam that I've ever done. But the parents were worried about putting the child under anesthesia, and so they wanted to try an ERG that was awake. So we tried that. But I always tell people, I have 2 kids myself, and my oldest child, even at 11, 12, 13, there's no way I could have gotten him in an ERG. Absolutely not. Would not do it, under any circumstances. My youngest child would absolutely have done it with no problem, even as young as 6 or 7. So like each, kids are very individual, and some can do it and some cannot.
Yeah, I remember I asked this question of someone years ago, what the youngest multifocal she'd done on a pediatric patient was. And she said, the thing is that I've done a successful multifocal on a 5-year-old, and she was just a dream, an adorable kid. Super helpful, super cooperative, great response. She came back the following year and she bit me. So she said, it really depends on the kid that day, what the weather is like, and how recently they ate, and if they've had a nap and all of that. So
it's very, very kid dependent. For sure.
Switching gears a little bit, how many ophthalmology centers in the US or around the world would you estimate are already considering genetics as part of their diagnosis or diagnostic process?
So I don't know an exact number, but it's high. I would say that most of the retinal specialists that I work with are actively doing genetic testing. So most of the referrals that I get for ERG come from neuro-ophthalmology or retinal specialists. And I would say that by far and away the retinal specialists have already done the genetic testing, and they send for the ERG while they're waiting for the testing to come back, so that they have both pieces of information when the testing comes back in, since the genetic testing takes about a month. And then the neuro ophthalmologists, I don't feel like are doing the genetic testing as much because they're more focused on neuro and brain conditions than they are on retinal conditions. So for those patients, if the ERG is abnormal, I will usually run the genetic testing myself and send the report over, to which sometimes I get a, "Why are you sending this to me?" And I'll respond that I just thought that you might want to have it for your patient's record. But I even sometimes get notes from retinal specialists asking me please not to do the genetics if I think that it's warranted, because you can do it once every 3 years through the Foundation for Fighting Blindness. And if we're not linked together, then when I run the test, they can't see it in their portal. So sometimes they want to wait and do it in their own portal. But I will say there have been a handful of times I've repeated it in office, because a lot of times they send the patients home with spit tubes. So, there's 3 ways that you can get the genetic material. You can do a buccal swab, you can collect saliva, or you can do blood. And so a lot of times the kits are sent home with the patients. They collect it themselves and mail it. But if I do it, I usually do it in office. So I'm collecting the sample for the patient or helping them collect it. And we always use buccal swabs because they're the easiest. And patients who cannot see well have a lot of trouble collecting saliva. So if you can't see the tube and the saliva is clear, what you end up doing is spitting around the whole outside of the tube, which is really messy and gross. And then the person who's helping you, right, then is like touching all your spit and stuff. And people don't usually have a whole lot of sets of gloves at home, right? So the whole thing just gets kind of messy and icky. So if you are going to send the patient home with a kit, I'd recommend a buccal swab. And I have occasionally repeated in office buccal swab testing for patients that were sent home with a saliva test. So I don't know if that completely answers the question or if I went off track, but
No, that's extremely helpful. Do you have any other guidance, if you were to give any suggestions or guidance to someone who wanted to start using genetic testing? Is there any other guidance that you'd want to offer them about things that they maybe hadn't thought of, or practical information like saliva collection is not nearly as good for low vision patients as buccal swabs, that sort of thing?
Yeah, I generally feel like if there's a way, if you have a patient who has low vision and there's a way that you can help them collect the sample in office, it's far more successful, because the consent form is electronic and it's small and hard to read. And they have to log in and out of it several times. And the tube that they collect the sample with is also small and hard to maneuver. So I find with my low vision patients, I'm far more successful at actually getting the testing done if I do it when they're with me. Now, the other patients who see better do just fine doing it on their own at home. So you can send the sample home with them, and it comes with a FedEx bag that they can mail back. And so a lot of patients are able to do it successfully at home, but not all the patients. So I might say, like, read it by the specific patient. And if you really want those test results, and you think the patient's going to have difficulty with it, considering having them do it in office. It doesn't take that much time to do. They just need to not eat or drink anything for about 20 minutes before the test, right? So whatever they eat or drink doesn't contaminate their sample. And then they either just spit in the tube, but it's a lot of spit, right? So if it's a saliva test, like, they have to keep spitting and spitting and spitting. I usually tell them to think about a pickle, and that kind of like makes your mouth start to water. But a lot of times it takes a while to do the saliva test. The buccal swab is very, very easy. I feel like switching from saliva to buccal made my life a lot easier. Somebody who collects these. So,
All right, and I have one last one for you. As we're working on modifying our lab to be a better utilized tool for diagnosing patients, when do you decide to use the ICEV standard ERG versus a modified or extended protocol like S-cones or on-off ERG sort of things?
I usually start with the ICEV standard ERG because I feel like it's kind of universal, right? I can share the ICEV standard ERG with any other lab, and the test results are kind of universally understood. And then if I want to, for a particular patient or study, dive in deeper, right, and really learn more about their ERG, then I go into more extended protocols after that. So, sometimes in a research setting that would require more than one visit or a long time in an ERG. For the clinic patients, sometimes it's hard to get them to do lots and lots of testing in the same day. But usually in a research lab, people can set aside more time to be able to do some more of those extended protocols. But I like always having the ICEV standard ERG if I can, just because I feel like it's so comparable across the literature, and across other labs and testing arenas. I hope that answered the question.
Excellent. Well, I think that's pretty much all the time we have for questions today. Thank you again, Wendy, so much for your presentation and for all of your answers to the great questions. Thank you to our attendees for your great questions. And another thank you to everyone who attended today. If you're interested in learning more about diagnosis systems, please contact your local diagnosis sales or support person, myself included. If you're unsure who that is in your region, you can find their contact information on our website. If you're interested in signing up for the Diagnosis newsletter so you can be notified of future webinars, you can do so at diagnosisllc.com/newsletter. This will keep you updated on future webinars we plan to host and also other great things happening in our field. Finally, if you plan to attend ARVO in Denver in just a couple of weeks, then we invite you to stop by our booth and say hello. So thanks again, everyone, and have a great rest of your day.
Thank you, Natalie. And I hope to meet people, especially when my voice is a little bit stronger. Hopefully everybody could hear and understand everything that we said. So I really appreciate it, and the invitation to speak.
Awesome.